Hello, good evening. I hope you all can hear me. So welcome to a limited series of classes, 3 classes done by Dr. Yanushka Herath as well as by myself. I am Dr. Harindri Athukorala. I am a senior registrar in endocrinology. So I'll be starting off this today's session, and we'll start with the true false MCQs. And after that, Dr. Yanushka Herath will join the discussion and he will discuss the rest of the SBA. Let's start with the true false. Right. So I hope you can see the screen. The 8th question, which is the first MCQ question. It's a 64-year-old man with hypertension and previous PCI. So it is actually a cardiology question. So that will be discussed by Dr. Yanushka as he is a consultant cardiologist. So we'll start off from the second one, which is the 9th question. A 70-year-old man presents with acute left-sided weakness and slurred speech 90 minutes after symptom onset. Blood glucose is normal. CT brain shows no hemorrhage. So what do you think it is? So the first glance, it is a 70-year-old man with acute left-sided weakness. The key is the word acute. So that means they want to let you know that it is actually a stroke. So left-sided weakness with the word acute in front of it, that means it's an acute stroke. So the next step would be to realize when the symptom onset has occurred. Why? Because it's important in our management. Because if it is less than 4 hours, you can go ahead and do the thrombolysis, right? So, and the other thing is whether the stroke is actually a hemorrhagic in nature or whether it is a ischemic stroke, right? So for that, you need to do a CT brain, NCCT brain. If there is no hemorrhage, that means usually you take it as an ischemic stroke, right? The next step before thrombolysis is to go ahead and do a blood glucose. Why? We know hypoglycemia, especially severe hypoglycemia. So hypoglycemia in a non-diabetic is less than 55 milligrams per deciliter. In a diabetic, it's less than 60 milligrams per deciliter. So hypoglycemia per se can present, it actually can mimic a stroke, right? So hypoglycemia, remember, can mimic a stroke. So that's why, and for those kind of things, you're not going to go ahead and do the thrombolysis. Only for ischemic strokes, you're going to go ahead and do the thrombolysis. So you need to make sure that the patient is not hypoglycemic, and hence why you have to do, it's mandatory to do a blood glucose before going ahead with your stroke management. So here the blood glucose is normal. It's within the time limit of less than 4 hours. And the CT brain shows no hemorrhage. So it's an acute ischemic stroke. The next step before thrombolysis would be to exclude any and if at all contraindications for thrombolysis, right? So you can, if you don't know, you can even search and see or refer to our notes. So you have absolute contraindications for thrombolysis and relative contraindications for thrombolysis, right? So you need to tick one by one. There is actually in every emergency room or the ER, you will be having a sort of a tick list where you go through each and every one to look for any contraindications, either absolute or relative contraindications for thrombolysis, right? So here they have not really given any other obvious contraindications for thrombolysis. So you can go ahead and thrombolyze the patient. Now, one thing you need to know is this is a 70-year-old man. You might think whether the age matters in thrombolysis. So age matters only towards the younger side. So more than 18 years has to be there for you to thrombolize, but there's no upper limit of your age for you to go ahead and do the thrombolysis, right? So having those things in your mind, let's go to the questions. So thrombolysis may be considered if no contraindication. So like I said, if it is an ischemic stroke with a normal blood glucose and there are no contraindications that you have gone through the list, you need to know the contraindications. So if you don't know, you can easily search and get the list of contraindications, right? So thrombolysis may be considered if no contraindications. That is absolutely true. So blood glucose should be checked early in all suspected stroke. Like I told you, low blood glucose, so what we call hypoglycemia, is a mimic of acute stroke. And, if you don't do the blood glucose, you might miss a hypoglycemia and you might think that it is a stroke and do the CT, and you may not see a hemorrhage and you can go ahead and falsely thrombolize the patient as well, right? So to prevent that, you always need to do a blood glucose. So they say, what the guidelines say is that there are only 2 investigations for you to do in an acute stroke. You don't have to wait for anything, any INRs, any electrolytes, any creatinine levels, any STLT, any full blood count. You're not going to wait for those. You're only going to do 2 investigations. That's what the guidelines say. What are the 2? The first one would be a blood glucose level. The second one would be an NCCT brain, right? So those are the only 2 investigations needed before you go ahead and thrombolize a patient in an acute stroke setting. So blood glucose should be checked early in all suspected stroke as it is a mimicker. Aspirin should be given before excluding hemorrhage. Absolutely not. It's a false statement. Why? If you do give aspirin, the loading doses, this is a common mistake that we see done by the GPs. They just load the patient with aspirin and clopidogrel and atorvastatin and send the patient to the hospital for a CT, which is absolutely wrong. Why? You need to completely exclude a hemorrhagic stroke by doing an NCCT brain. So after you have done the NCCT brain, you review it, see that there is no hemorrhage, and then only you're going to go ahead and do the rest of your management. So if you're going to do thrombolysis, you're not going to load with aspirin and clopidogrel. You're just going to go ahead and give the thrombolysis. But if the patient has contraindications for thrombolysis or it is past the acute stroke stage, so then you can go ahead and give the aspirins and the clopidogrel, right? D, severe uncontrolled hypertension may be a contraindication to thrombolysis. Yes, so if you go through the contraindications, severe hypertension is an absolute contraindication for thrombolysis. So for you to start thrombolysis, the blood pressure has to be less than, the SBP has to be less than 185. And then while giving the thrombolysis, for you to initiate, it should be less than 185. And for you to continue giving the thrombolysis during that period and afterwards, you need to get it down to less than 180, right? Then early swallowing assessment is important. Yes, absolutely. Why? Otherwise, the patient can, if you don't take the necessary measures and you do give some oral tablets or whatever, imagine you give oral aspirins or whatever to the patient has a swallowing difficulty, he can aspirate, right? Or if he has severe swallowing difficulty, he can even aspirate his own saliva, right? So you need to be very careful. In a stroke patient, you need to do a swallowing assessment before you start oral feeding or anything oral, right? So that is important. Moving on to the 10th question. A 36-year-old woman presents with weight loss, tremor, and palpitations. Now, she has a diffuse goiter and mild eye signs. TSH is suppressed and free T4 is elevated. Now, before the key to answering questions, especially SBAs, right, is to go through the question very carefully and don't look at the responses straight away, right? Think about the question a little bit. Try to understand what clinical scenario that they're talking about. Usually, it will be straightforward, right? Now, here, they do give obvious features of thyrotoxicosis in the first sentence itself. And in the second sentence, I mean, what else it can be? Weight loss, tremor, and palpitations, right? So it is a thyrotoxicosis. Then in the next sentence, I mean, they give you the condition straight away. So that is the good thing about your exams. The ERPM exams as well as the final exams, they don't want to overcomplicate things. They'll be straight away giving you the scenario without hiding facts, right? So the second sentence says she does have a diffuse goiter, right? So you know now this is a thyrotoxicosis of a 36-year-old woman. Then they go on to say that the patient has eye signs. So whenever a patient comes with thyrotoxicosis and features suggestive eye signs ophthalmopathy suggestive of thyroid eye disease, it's unless otherwise stated, it's Graves' disease, right? Because in other thyrotoxicosis causes, like the toxic multinodular goiter, toxic adenomas, and so on, they will not really give you the eye sign, right? What do you call the thyroid eye disease? So thyroid eye disease is only present in Graves' disease, right? So what are the thyroid eye disease signs that you do know when you see the patient? The proptosis, the chemosis, right? Those things are obvious. Then conjunctival edema, right? Eyelid edema. Then conjunctival redness. Okay. So those are then obvious ophthalmoplegia, any and obvious ophthalmoplegia, right? So those things are called thyroid eye disease. Now keep in mind, lid lag and lid retraction does not fall under thyroid eye disease, right? It can happen in thyrotoxicosis because of the hyperadrenergic condition that occurs during the thyrotoxicosis. So you know, thyrotoxicosis means there is a adrenergic stimulation. So hyperadrenergic state in the body. As a result, the orbicularis oculi muscle can get chronically contracted, and that's when you do get the lid lag and lid retraction, which can occur in any cause of thyrotoxicosis, right? And it's not specific. Lid lag and lid retraction are not specific for Graves' disease. But the rest of the features I mentioned, ophthalmoplegia, chemosis, conjunctival edema, conjunctival redness, eyelid edema, eyelid redness, plica inflammation, ophthalmoplegia, those things are typical thyroid eye disease features, and they only are present in Graves' disease, right? So then the next sentence says TSH is suppressed and FT4 is elevated, which is the biochemical indication of thyrotoxicosis, right? So the first statement says Graves' disease is likely. So I told you, if you do have thyroid eye signs, then it is definitely Graves' disease. So that is true. Then beta blockers can improve adrenergic symptoms. I told you thyrotoxicosis is a adrenergic condition, hyperadrenergic condition. So you need to treat, when you're treating, you need to aim for adrenergic symptom relief as well, which is done by mainly beta blockers, right? So you can use propranolol, then atenolol and esmolol. Those three are the main beta blockers that we use in thyrotoxicosis. And beta blockers can only relieve the adrenergic symptoms in the thyrotoxic storm in quite high doses, right? So 40 TDS, 20 TDS doses like that you can give for thyrotoxic crisis relief. Another MCQ that they can ask is that beta blockers what are the functions of beta blockers in a thyrotoxic crisis, right? So one thing, they relieve the adrenergic symptoms like what? The palpitations, they reduce the heart rate. If the patient is already in an AF, they reduces the rate, right? So those things and the rest of the adrenergic symptoms like severe sweating and so on, you can get a symptomatic relief out of beta blockers. They have another purpose. What is it? In high doses, it will also prevent the peripheral conversion of T4 to FT4 to FT3, right? So you know the thyroid gland releases FT4 in high amounts and only a little amount of FT3. So FT3 is the physiologically active component of the thyroid hormones, right? So for you to get the benefits of thyroid hormones, it always have to come in FT3. So the thyroid gland only releases FT4 in large amounts. So in peripheral tissues, the FT4 will be converted to FT3, which is the active thyroid hormone, right? So in thyrotoxic crisis and thyrotoxic storm, we don't want this conversion to happen. We don't want the active form of thyroid hormone to be formed, right? So beta blockers are helping in that as well in high doses. So like 40 TDS to 40 BD doses, it will prevent the peripheral conversion of T4 to T3 as well. So there are two advantages of giving beta blockers. Then what is carbimazole? Carbimazole is an antithyroid drug, right? The other antithyroid drug that you know is the propylthiouracil. So in an acute thyrotoxic storm, you always manage the patient with propylthiouracil. If not, in other thyrotoxicosis, like mild forms of thyrotoxicosis, you can use carbimazole. So one of the dreaded side effects of carbimazole is agranulocytosis. What is agranulocytosis? It reduces or it suppresses the production of white blood cells, right? Especially there will be a neutropenia. Neutropenia due to agranulocytosis will cause you to get severe contraction of severe infections, right? So it is a dreaded side effect because the mortality if a patient develops agranulocytosis will be high. So you need to, if it is a very ill patient, you'll need to monitor the full blood count during the ill state. But we usually in a normal thyrotoxic patient without any severe without any severe compromise like a severe thyrotoxic storm, a normal thyrotoxic patient on carbimazole, we wouldn't be monitoring the full blood count with full blood count regularly. But you have to educate the patient that something like this can happen. So by if any chance the patient develops fever, cough, cold, sore throat, to stop the carbimazole and immediately to come to the hospital with a full blood count, right? So you need to tell that to the patient. So carbimazole can cause agranulocytosis. That is true. That is one of the dreaded side effects of carbimazole. Then radioiodine is preferred during pregnancy. Now, after you manage the acute thyrotoxic condition, right, you need to offer a permanent solution for the goiter of the patient. So it can be of three things. You can either continue to manage the patient with antithyroid drugs. However, the relapse rates and, side effect development and everything will be high when you continuously use antithyroid drugs for a long time. You can also, as a second option, use radioactive iodine to disrupt the gland, right? And the third option would be surgery. So talking about radioiodine, now radioiodine can be given in all thyrotoxicosis causes as well as in thyroid cancers, right? So here we are talking about just managing the thyrotoxicosis. So one thing you need to know about radioiodine, it's very teratogenic, right? So you never ever give it during pregnancy or lactation. It's extremely teratogenic, right? So you need to make sure the patient being given radioactive iodine is not pregnant. So you need to have a negative pregnancy test 48 hours before giving radioactive iodine to a woman, that is. And you have to advise her not to get pregnant for at least 6 months duration and make sure the patient is on contraception. For a male, you need to make sure that he will not father a child during the coming 4 months time at least. So radioactive iodine in very high doses sometimes can cause male infertility, but it is not it does not cause female infertility, right? So radioactive iodine is absolutely contraindicated pregnancy. So this statement is false. Another thing you need to know about radioactive iodine is that it's contraindicated when you have moderate to severe thyroid eye disease. In mild thyroid eye disease, you can actually consider radioactive iodine, but if the patient has severe or moderate thyroid eye disease, you don't need to know how to classify what is severe, what is mild, or what is moderate, but just know that if the patient has thyroid eye disease, radioactive iodine is not the first line, right? Because another MCQ point is radioactive iodine can actually worsen thyroid eye disease in Graves' disease. Okay. Moving on to E, thyroid storm is a medical emergency. Yes, we were just talking about it. So one of the MCQs that they would ask you is how do you diagnose the thyroid storm? So thyroid storm is diagnosed by a scale called Birch-Wartowski scale, right? Birch-Wartowski scale. So if you have not heard about it, maybe you can Google it. So Birch-Wartowski scale, right? BURCH Wartowski, WOR Wartowski, TOSKY scale. So it is like it has several symptoms and findings that you can give points to. And then if the total score adds up to more than or equal to 45, that is how you diagnose a thyroid storm, right? So thyroid storm is actually a medical emergency. You cannot manage it as outpatient. You need to admit the patient and give IV medications, right? Okay, so going into the 11th question. A 59-year-old man with CKD stage 4 presents with weakness. ECG shows tall tented T waves. Serum potassium is 6.8. So you're going to think about this statement for a while. It's a 59-year-old CKD stage 4 coming with weakness. Why do you think that is? So now they are saying serum potassium is 6.8. That is a hyperkalemic patient. And the hyperkalemia is confirmed by the presence of tall tented T waves in the ECG. That is a feature of hyperkalemia, right? Tall tented T waves. Why do you think the patient is presenting with weakness? So one of the rare presentations of hyperkalemia, even severe hypokalemia can cause this. So both hyper and hypokalemias can cause a periodic paralysis. Because for our muscles to function, potassium is, the electrolytes are needed. You know that. So any problem with calcium, any problem with potassium, any problem with sodium, the patients can present with so many presentations, and especially so many musculoskeletal presentations. So hyper and hypokalemia presentation is one such occasion where the patient will present with acute flaccid paralysis of bilateral lower limbs, right? That is what you call. And when you examine, there will be a flaccid weakness, no reflexes or hyporeflexia. And two of the causes are either hypo or hyperkalemia. So here, the cause why the hyperkalemia is also given quite obviously stage 4 CKD patient. So we know CKD can give rise to a hyperkalemia, right? So this is a hyperkalemia due to CKD coming with possible periodic paralysis, right? So the first one, they're actually asking about the management of hyperkalemia. I was just talking about some background knowledge for you. So IV calcium gluconate stabilizes the myocardium, absolutely. So how you give it is the 10% IV cal gluconate, right? 10 ml to 30 ml. We used to say 10 ml. Now they say up to 30 ml you can give. And you have to, the most important thing as HOs for you to know is that when you're giving it via a peripheral line or whatever the line, you have to give it very slowly. So if you're giving like 10 ml, you need to infuse it over 10 minutes. If you're giving more than that, you need to infuse it over even more. So very slow injection is how you give the calcium gluconate because it will otherwise destabilize the myocardium. The whole purpose why we are giving IV calgluconate in hyperkalemia is only to stabilize the myocardium, right? So if you load the patient suddenly with IV calgluconate, the whole purpose is gone. So you need to really slowly infuse it, right? And the purpose is only to stabilize the myocardium. It will have no effect on the total body potassium or reducing the potassium levels in the body, right? It only purpose is to stabilize the myocardium. So it's true. B, insulin with dextrose shifts potassium intracellularly. So insulin will, insulin will sort of drag the potassiums into the cells and reduce the extracellular, the serum free potassium levels. Why do you give dextrose with it? Now imagine if somebody injects insulin into you, your blood sugars will go down, right? So we give insulin dextrose together to counteract the action of insulin. We want the high levels of insulin to grab the potassiums into the cells. And at the same time, we don't want the insulins to go and give us a hypoglycemia. So that's why we are combining, right? And the insulin and the dextrose together will shift the potassium intracellular, which is true. Nebulized salbutamol may help lower serum potassium temporarily, which is also true. You know, when you give continuous nebulizations of salbutamol in acute asthma attacks and so on, the serum potassium level tends to go down. So salbutamol also has an action of shifting the serum potassium into cells. So that is true. Calcium gluconate lowers total body potassium. I told you they do not have any effect on the total body potassium lowering or otherwise. They just stabilizes the myocardium. That's false. So what do you do if the hyperkalemia is refractory to your medical management? Then of course you need to go ahead and do dialysis for the patient. So dialysis is the last option for you to manage a refractory hyperkalemia. So that is true. What do you mean by refractory? A patient who is not responding to the medical management, right? That is when you go for dialysis. Right. 12. A 24-year-old asthmatic patient a 24-year-old asthmatic patient with severe wheeze, inability to complete sentences and oxygen saturation of 88% on air. There is widespread bronchi. Give me a second. Right, so the 24-year-old asthmatic coming with severe asthmatic episode, right? There's widespread bronchi. So this is a acute severe asthma. High flow oxygen is appropriate initially. So you can start nebulizing. After nebulizing with salbutamol, you have to obviously give oxygen to these acute asthma patients, right? So one of the very efficient methods of giving oxygen into a asthmatic patient would be a high flow oxygen machine. It is not widely available, especially not in peripheral units. But in tertiary care hospitals, you might get a high flow oxygen, and it is absolutely recommended for you to give high flow oxygen, right? That's true. Nebulized salbutamol should be given urgently. Absolutely true. That is the treatment along with IV steroids like IV hydrocortisone and IV salbutamol and IV ipratropium, right? Then if it is not responding to all those medications, you can give IV magnesium sulfate 2 gram over 20 minutes, right? So again, it's a very slow infusion. You need to give the 2 gram over 20 minutes. So IV magnesium sulfate may be used if poor response to initial therapy. That is true. Antibiotics are mandatory in every acute asthma attack. Of course, it's false. Antibiotics are only recommended if the patient is having an acute infection, either a respiratory tract infection causing the acute asthma attack, uh, in acute asthma, acute severe asthma. So otherwise, there is no place for antibiotics. Silent chest is a life-threatening sign. That's true. So inability to talk because of the breathlessness, silent chest, all of these things are features of life-threatening asthma. So you know there's mild asthma, moderate asthma, severe asthma, and life-threatening asthma. So you need to know how to categorize the patients into each. I'm sure in pediatrics as well as in internal medicine both, you need to know this classification, right? So you have pulse rate, respiratory rate, saturation, how many words the patient can talk, or if not, cannot talk at all, silent chest, so and so on. There are several features that classifies a patient into mild, moderate, severe, and life-threatening asthma. So question number 13, a 22-year-old man presents with fever, severe myalgia, conjunctival suffusion, and oliguria after working in flood water. Platelets are low and creatinine rising. So fever, a young patient, otherwise healthy with fever, severe myalgia, conjunctival suffusion, and oliguria. So there is fever, myalgia, and then an AKI, right? Acute kidney injury, because the creatinine is rising, and there's oliguria. So you call it acute kidney injury. And there's thrombocytopenia as well. So the two TDs would be dengue fever and the leptospirosis. Here it's obvious leptospirosis because the patient has been working in muddy water as well as an AKI is going on. So if you have those two in a patient with fever and thrombocytopenia, you're going towards leptospirosis. If there is no history of muddy water contact or there's no AKI going on, you tend to consider dengue fever in a patient with fever and platelets, right? So for leptospirosis is a possible diagnosis. Yes, here it's absolutely true. Acute kidney injury may complicate the illness. Yes, so a form of severe leptospirosis is what you call the Wales disease, right? Wales disease. So Wales disease comprises of a severe form of leptospirosis, which has the components of acute kidney injury, hepatitis, not a liver failure per se, but a hepatitis or a meningitis, right? So those three conditions can complicate your normal leptospirosis patient, and this is when you call the Wales disease. So acute kidney injury may complicate the illness, that's true. Conjunctival suffusion supports the diagnosis. Absolutely true. So this is a fact that you need to remember, right? So conjunctival suffusion, if you do have in a patient, you tend to suspect whether this is lepto. Antibiotics should be delayed until serology confirms the disease. Absolutely not. The moment you have a doubt whether this is leptospirosis, you load the patient with antibiotics, right? So a third generation cephalosporin is the best antibiotic for leptospirosis. So ceftriaxone is what we usually give. And or cefotaxime also you can give, right? So any third generation cephalosporin is fine, but you need to give the antibiotic without waiting for serology or the PCI, right? So that is false. Dialysis may be required in severe renal failure. That is absolutely true. Initially, in the initial stages, you can monitor the patient, but if the patient develops significant uremia or fluid overload due to the acute kidney injury, you can offer dialysis, right? So, 14th question, a 45-year-old woman presents with tiredness and exertional dyspnea. HB is 8.4. MCV is 68, which is low. Ferritin is low. She reports heavy menstrual bleeding. So, what you need to know here is she's presenting with symptoms of anemia, tiredness, and exertional dyspnea, right? Now, then they confirm it by saying HB is 8.4, which is anemia. So, she's having symptomatic anemia. Now you need to think what the causes are. So in a woman with heavy menstrual bleeding, the first thing you need to think about is iron deficiency anemia due to her heavy menstrual bleeding, right? So what are the things that will confirm the iron deficiency anemia? The patient will have a hyperchromic microcytic picture in her blood picture. So here the MCV is low, that means it is microcytic, right? Then you have to go and do a serum ferritin level, serum iron studies, right? So here they say ferritin is low. It confirms the iron deficiency anemia. So in an iron deficient patient, you have to replete her of iron. So initially you can start with ferrous sulfate, right? So ferrous sulfate 1 tab daily with vitamin C 1 tab daily is enough. But at least you have to give iron tablets and then monitor her for the response. So what they usually say is you have to get at least 1 HB up every 2 weeks' time. And when the HB is back to normal and the serum ferritin levels are back to normal, again you have to continue for another 3 months. The iron tablets has to be continued for another 3 months' time, right? So initially you can try the oral formulations, but usually patients report very significant side effects, right? So usually how do you advise the patient on taking oral iron is before a meal, right? Maybe in between meals. Most of the time patients cannot tolerate that. So they will all come to you and tell either gastritis or nausea, vomiting. They cannot really tolerate the tablet. In that case, what you can do is you can ask the patient to try it with food also. You can ask the patient to try it. But sometimes they cannot tolerate that also. In that case, you'll have to go ahead with IV iron in those particular patients, right? So iron deficiency anemia is likely, that is true. Oral iron is appropriate if she is stable and able to tolerate it, that's true. Reticulocyte response can help assess treatment response, yes. Retic count response, you can definitely see, but we usually what we tend to see the response with is the every 2 weekly full blood count where one unit of HB has been increased. So this is also true. You can use the reticulocyte response as well. Then D, blood transfusion is routinely required in all patients with HB less than 9. That is false. So usually if the HB is less than 7, that is an indication for you to transfuse the patient without any ischemic heart disease. If the patient has ischemic heart disease, usually if the HB is less than 9, you can transfuse the patient. And in any situation where the HB is low, any HB is low, any value of HB, but the patient is having symptoms, then it is an indication for you to transfuse blood. So 3 indications. If the patient is not having any ischemic heart disease, 7 is the target. If the patient is having ischemic heart disease, you have to maintain the HB at 10 or more, right? And if the patient is symptomatic, you need to transfuse with blood, right? The cause of iron loss should be addressed, of course. So there's absolutely no point in you just giving her iron without addressing the root cause here, which is the heavy menstrual bleeding. So you need to give something to control the heavy menstrual bleeding in the acute stage, right? something like a noethistron or mefenamic acid and so on. And then you can refer her to a gynecologist to address the heavy menstrual bleeding. So root cause has to be addressed. Then 15, a 50-year-old man presents with hematemesis and melena after taking NSAIDs for back pain. So it is an NSAID-induced peptic ulcer disease causing hematemesis and melena, right? BP is 92/60. Patient is unstable and the pulse rate is 118. So this is a medical emergency. You urgently have to get wide bore cannula with IV access. Resuscitate the patient with IV fluids. A lot of IV fluids, which is normal saline, right? You don't resuscitate with colloids. It's just normal saline. And then you have to send blood for a grouping and DT. And if the patient keeps on deteriorating and the blood is not yet cross-matched, in an emergency setting, you can even get cross-matched blood and then give the patient as a life-saving measure, right? So that is true. IV PPI have maybe started before endoscopy. That's true. You can start IV PPI, IV omeprazole, 80 milligrams stat, followed by 8 milligrams per hour infusion. So you have to start this immediately because we have to resuscitate the patient and book a endoscopy room and everything for us to go ahead and do an endoscopy. When the patient is unstable, we are definitely not doing it. So we need to resuscitate first and it will take some time. So you need to start the IV MPP stat dose as well as followed by the infusion. Endoscopy should be planned after hemodynamic stabilization. Yes, you can go ahead and do interventions on the bleeding peptic ulcer like argon plasma injection or other injections and so on. So you need to go ahead and do an endoscopy. Discharge is safe once vomiting stops. So I wouldn't really say that is true because for you to discharge the patient, he has to be hemodynamically stable, not just vomiting being stopping. I mean, he was having melena as well. So when there's an ongoing melena, you're not going to discharge. So this is false. Just when the vomiting stops, you're not going to discharge. H. pylori testing may be relevant after stabilization. Yes. So there was this trend of just starting H. pylori kits in patients suspected to be having H. pylori infection. But now they say you always have to test and confirm that the patient has H. pylori infection before going ahead and treating with H. pylori kits. And after treating, after the completion of treatment as well, you need to test and confirm that the infection is no longer there, right? So H. pylori testing has to be done. So those are the true-false questions. There was another SBA suggestive of DK. So we'll talk about that also, as endocrinology is my specialty. So if you go to the SBA questions, the third question, right? 29. Now, SBA especially, you need to do what I told you. You first go through the question and understand what the scenario is and formulate the answer before going into the given responses. Then the chances of you being wrong are quite low, right? So 29-year-old woman with type 1 diabetes presents with vomiting, abdominal pain after missing insulin during a febrile illness. She is dehydrated, breathing deeply and smells of ketone. Capillary blood glucose is 28 millimole per liter. So quite high. She's having about moderate to definitely more than moderate DKA because she's dehydrated and breathing deeply and smells of ketones, which is called the Kussmaul breathing. The deep sighing-like breathing is what you call the Kussmaul breathing. So when you have Kussmaul breathing, when she's dehydrated and when the breath literally smells of ketones, it's a severe DKA, right? So what is the most appropriate initial management? Now think, in a severe DKA, what is the initial management? So as in any emergency, first you're going to resuscitate if he or she is hemodynamically unstable. So here they have not really told us the patient is hemodynamically unstable. So we don't have to think about, vigorously resuscitating like in a normal patient with shock, right? So in a next severe DKA patient, what would you do? Now they say she's dehydrated, right? So you need to first of all hydrate the patient very well. Get IV access, send the necessary investigations like the full blood count, electrolytes, creatinine, CRP, blood culture, just to see what trigger. Then she's having a febrile illness as well. So whether there's any sepsis going on and so on, you need to send those investigations. Then after doing that, in a severe DKA, you need to start the patient on IV fluids. So IV hydration is the key, right? Then the second thing is you need to start the patient on IV soluble insulin infusion. So you can manage with subcut soluble insulins if the DKA is mild. So again, there are specific criteria to categorize a patient as to having mild DKA, moderate DKA, and severe DKA. So in a mild DKA patient, there is a place for you to manage with subcutaneous soluble insulin, which is a rapid-acting soluble insulin. But here the patient is severely dehydrated, kusama breathing, smells of ketone, vomiting, abdominal pain. You are not going to go ahead and categorize this as a mild. This is absolutely a severe DKA. So in that case, IV insulin infusion has to be started. And we discussed insulins cause hypokalemia, right? So you need to know the potassium value ideally before starting the insulin infusions. But if you cannot do that in the acute setting, you can even give a little bit of potassium and start the insulin infusion along with that. So let's go to the responses now. Subcutaneous rapid acting insulin only. So I told you it's IV insulin infusion. B, IV fluids, potassium assessment, fixed rate IV insulin infusion. That answer gives everything that I told you, no? Right. So IV bicarbonate immediately in all cases. You're not going to give IV bicarbonate to DKA patients unless the pH is less than 6.9. So 6.8 or below only. With senior opinion, you're going to give IV bicarbonate. Never ever give alone. You always have to consult a senior, right? So that's false. Oral rehydration is out of the question. The patient is vomiting. You can't really give oral rehydration. You have to give IV rehydration. Then stop insulin until potassium result is available. I told you it's ideal settings. We would like to know potassium level before starting IV insulin, but you can always give a little potassium and start the insulin infusion. So everything that we have told will be explained by the B response, IV fluids, potassium assessment, and fixed rate IV insulin infusion. So that would be your single best answer. So that is all for now. Is Dr. Yanushka logged in?
I'm here, right?
Right.
Me thanks, right. Can you keep the screen?
Sure.
Your shared screen.
Sure.
Right. Me are cardiology question එකක් තිබ්බ ඒක කරාද?
No.
Right, I'll do it. Okay, so we'll start. Me ඉන්නවද කවුරු කතා කරා නම් මට ඇහුන්නේ නැහැ හැබැයි.
Yeah, there are like 12 participants, I think.
කට්ටිය ඉන්නවද? Right. Okay. Recording set එකක් තින්නවන්නේ. Right. Okay, so first question, right? First කියන්නේ මේ MCQ first එක. So 64-year-old man with hypertension, previous PCI, presents with exertional chest tightness, relieved by rest, ECG normal at rest, troponin negative, already on aspirin and atorvastatin, right? So we'll talk some scenarios here. So based on the clinical scenario, what is the diagnosis? Anybody? මේ කවුරු හරි කියන්න පොඩ්ඩක් නෝන. Wait. Yeah, anybody? Shall I'll point out. I'm like doing from my phone. Sorry. Devindi, yeah. Devindi, what do you think the diagnosis here is? At least anybody you can send a message even if you're scared of talking. Yeah, good. So very good. So it is a stable angina. So this clinical scenario point towards it's a clear-cut thing. And
Excuse me, Dr.
yeah, you can you can off it.
Stop.
Yeah.
Okay.
Right. Sorry. So this is very good. So this is a clear-cut angina. So angina, the classical description is you get an exertional chest pain when you walk a few distance, and tightening pain. They stop with the pain. It will be relieved at rest, or you take a GTN spray ගහුවට පස්සේ reduces, and that is a classical angina scenario. And in an angina, troponin will be normal and generally normal, and ECG, resting ECG will be gone. So now if a patient with angina comes to you, how will you investigate? What are the investigating modalities? Now these are the few things which was changed recently, and they expect you to know this as well. So what they do is, when a patient with angina comes, you have to categorize the patient as a low risk or a medium probability. It's not the risk, it's actually probability, because there are these probability scores, or whether it's a high probability patient. For an example, if a patient previously stented and diabetic, long-standing diabetic, smoker, family history of young MIs, then of course the probability becomes very high. Then of course you can straight away go with the invasive coronary angiogram. So if the probability is a medium probability, then you can do a CT coronary angiogram. That is the preferred choice, or a perfusion scan, but perfusion scans are not readily available anywhere in the world. So CT coronary angiogram will be the preferred choice. And if the probability is low, the guideline recommends is a CT calcium score. Guideline, they have kind of thrown away the stress echo, or not the stress echo, the exercise ECG. So exercise ECG is not even mentioned much in the guideline, although it's always done in Sri Lanka. Why? Because exercise ECG, it has a sensitivity and a specificity of around 60%. So there is a 40% chance, 30 to 40% chance the patient will be missed by that. And if you take a CT coronary angiogram, CT coronary angiogram එකේ අහන්න පුළුවන් එකම ප්‍රශ්න negative predictive value එක ගැන. So it has a 100% negative predictive value, which means if the CT coronary angiogram is normal, it is definitely normal. Always, that means the coronaries are normal. Like නිකන් බොරුවට normal කියලා පෙන්නන්නේ නැහැ. But problem in CT coronary angiogram is when there is calcium, it kind of appears as a block. So then sometimes CT coronary angiogram එක පෙන්නනවා 70% lesion, angiogram කරාට පස්සේ lesion එකක් නැහැ. So again, that is a small problem in CT coronary angiogram, but it's a non-invasive test. And so that is how you evaluate it. So once you diagnose stable angina, then of course treatment, I think you all already know. So first එක අහන්නේ, stable angina remains possible despite normal resting ETG. So here we thought, as you all said, stable angina is possible, and it is the diagnosis, so it is true. Sublingual GTN can be used for symptom relief. Yes, it is well known, and you have to give. But only thing is, there are few things in GTN also you have to remember. One thing is, if you give GTN, generally there is a rapid onset of symptomatic action. But you have to always tell the patient 2 times after using GTN, and still if you have chest pain, then of course you have to come to the hospital. Problems with GTN is you can get headaches. And other thing is, you should not use GTN with what? With phosphodiesterase inhibitors like sildenafil. And also GTN we tend to avoid in severe aortic stenosis. So troponin negatively excludes coronary artery disease. That is wrong. So in stable angina, by definition, troponin will be normal. But now we are using is a high sensitive troponin. We ගොඩක් hospitals වලත් තියෙනවා. So high sensitive troponin is very sensitive, and even the slightest coronary this thing, it becomes positive. So it's very difficult to manage with this troponin. And another common question for the exam they ask is, I always tell about this, what are the other causes which troponin can be positive apart from coronary artery disease? It's a very common, well-known MCQ. So anybody?
Myocarditis?
Excellent, very good. So myocarditis is a well-known entity which troponin becomes positive, and they present with a chest pain. But clinical history එක දුන්නොත් myocarditis එක, they might have a history of fever, and fever for about 1 week, and then coming with chest pain, ECG, there can be changes. Troponin will be positive, and echo එකක් කරාට පස්සේ echo එකේ there will be low EF with a global hypokinesia. And in order to diagnose myocarditis, is what we commonly use is the cardiac MRI, but the gold standard is the endomyosial biopsies of the heart. Very good. Anything else that troponin can be positive? So troponin positive you can categorize as cardiac and non-cardiac causes. So cardiac causes are cardiomyopathies, heart failure, even sometimes pericarditis can cause myocarditis, and almost all the majority of the cardiac conditions can cause increased troponin. But non-cardiac causes are sepsis is a well-known cause, pneumonia, and sometimes stroke. Stroke cause they can cause increased troponin. So you have to remember these causes, because sometimes it can be very confusing with ECG and all that. Next is beta blockers may reduce the frequency of angina. Yes, if you consider management of angina, once you clinically diagnose, then confirm with investigations, then what you do is you treat. So first line of treatment will be beta blockers. If beta blockers are contraindicated, you can add a calcium channel blocker. Beta blocker එකට හරියන්නේ නැත්නම්, you top of that you can add a calcium channel blocker, but make sure that beta blockers are not combined with verapamil or even diltiazem, because they can have extremely low heart rates and even heart blocks. And those two are the first line drugs. ඒක හරිය ගියේ නැත්නම් next line will be ISMN or ranolazine. That will be the second line. If ISM and ranolazine are not working, then the third line will be a drug called nicorandil. So nicorandil can be used if nothing is working. If all the drugs are not working, it's important, might be important for the MCQ also. They can ask trimetazidine is the last line of treatment for angina. Generally, with 2 drugs, angina cannot be controlled. You have to do an intervention. And continuing statin therapy is appropriate. Yes, for angina, we continue statin, and also you can give an antiplatelet as well, aspirin vagega denna puluwan. Right. So I think I covered almost everything about angina with the single MCQ. Any questions with angina? You all can ask anything. This doesn't have to be a traditional class. You don't have to be scared. You can just ask anything. I think that that is the benefit in our classes, because Kalimpa, I don't know, Sudhira කිව්වද දන්නේ මේ අපේ කලින් කට්ටියගේ performance ගැන ඒ හොඳට perform කරේ ඔක්කොමලා they always ask questions, and they have been regularly answering, and they got pretty good results, and so just including, I think last time පළවෙනි එක්කෙනා හරියට ප්‍රශ්න මට ගැන ඉන්න දුන්නෙම නෑ ඇත්තටම. So just you ask questions, and you can, that's how you learn actually. So we'll move on to the SBS. First question, 58-year-old diabetic comes with chest pain, 2 hours, ECG, ST elevation, low blood pressure, JVP elevated, lungs. So if someone asks a total diagnosis here, this is a clear-cut acute coronary syndrome with heart failure. So can anybody tell me what is the, based on this, what coronary artery might be involved? It's a bit of a tough question, but I mean, sometimes exams වල අහන එකක්. So now patient has low blood pressure, lungs are clear, JVP elevated. So obviously there is some heart failure thing going on. එතකොට මේක left heart failure ද right heart failure ද? Anybody? So this is a right heart failure. It's not a very good answers. I didn't now only I saw. So some answers are there. So all are thinking, majority are thinking it's a right heart failure. Then you have to think, me heart attack the මොකද මේ scenario එක you all have to know. One thing is you all have to pass the exam. Second thing is pass වෙලා medical HO උනාට පස්සේ රැට මේ heart attack එකක් ආවට පස්සේ මේ ඕක මේ හැම වෙලෙම SH වල කතා කරන්නත් බෑ, හරිය register වල කතා කරන්නත් බෑ. And sometimes you will මිනිහා answer කරන්නෙත් නෑ phone එක. So you have to always know how to manage the situation. ඒතර angiogram ගහන්න වෙලාවක් නෑනේ. ගහන්න බෑනේ හැමතැනම. ඉතින් then you have to know මොකද දැන් මෙයාගේ right heart failure එකක් එන්න නම් inferior මේ පැත්ත තමයි යන්න ඕනේ. ඒ කියන්නේ it should be the right coronary artery should be involved. So now you know this is an inferior STEMI, because obviously 2-3 AVF වල තියෙනවා ඒ territory එක right heart එකත් ගිහිල්ලා. So that means patient is having a very very low preload in the heart. So මෙහෙම එක්කෙනෙක්ට දැන් අපි හිතන්නේ cath lab එකකට we have to send the patient, or we are deciding on thrombolysis. Still the first line treatment, you can't give streptokinase or tenoctplase in a patient who is having right heart failure without managing it. You have to immediately start with IV fluids. This is very important. I mean, this is a very important concept, because in contrast, patient කෙනෙක් කෙනා anterior STEMI ඇවිල්ලා එයාගේ blood pressure low, lungs crepitations ගොඩක් තියෙනවා. So you can't go and give fluids into that patient. If you give fluids, that fellow is going to die. That patient, you have to give IV diuretics. But this patient, if you give IV diuretics, this patient is going to die. Why? Because preload is low. You have to give fluids as much as possible to increase the volume. Volume may then know me a patient. So clear cut, the answer is IV normal saline with urgent reperfusion therapy. Is it clear? Okay, clear. Then next question, 46-year-old man presents with sudden severe headache, vomiting, neck stiffness. Blood pressure high. CT kalla තියෙනවා. CT done after 3 hours. It's normal. What is the clinical but the clinical suspicion remain high. What is the next best investigation? Anybody? What is the diagnosis here you're thinking? මේ type කරන විනාඩියක් දෙන්න. Why B isn't? මේ question එකට දාන්න B ගැන. Yeah, I think you all are saying yes. B තමයි ඔක්කොමලා majority of you all is answering as B. So good. So why the lumbar puncture? This is a very classical question for exams and a classical scenario as well. So clear cut ne කවුරු හරි එනවා severe headache. මේකට කියන්නේ කොහොමද? Thunderclap headache. තමයි පොතේ තියෙන්නේ. That means worst headache ever. Classically මට ඕන තරම් කියලා තියෙනවා පොල්ලකින් ගැහුවා වගේ කියලා. මට I still remember one person told me අර මේ මෝල් ගහකින් ගැහුවා වගේ කියලා. It's severe pain and excruciating pain. So some they vomit and some මේක තව confuse කරන්න some people have fever as well because the meninges can get involved with this. And then they can have vomiting, classical neck stiffness, and their blood pressures will be extremely high. And CT classical signs CT to diagnose. But sometimes, because what happens is subarachnoid hemorrhage, there is bleeding into the subarachnoid space. And this is the space between the arachnoid matter and the pia matter. So කෙලින්ම CSF වලට යනවා blood. So majority of the time you can see it in the CT because especially when it's a large aneurysm, because commonest cause for subarachnoid hemorrhage is rupture of a berry aneurysm. And there are other causes as well. You have to always remember, especially trauma and AV malformation. Sometimes coagulopathies, vasculitis. So it is important to identify it, and because majority of the time berry aneurysm blood goes, well, you can see it. So what happens before going a few other clinical signs, making neck stiffness make confused meningitis differential diagnosis. And sometimes they can have this third nerve palsies, dilated pupils, and funduscope බැලුවම papilloedema තියෙන්න පුළුවන්. So it is very important to identify that. And especially කවුරු උසෙක් කෙනෙක් આવොත්, tall person, merm එකක් තියෙන එක්කෙනෙක් આવොත්, you have to always think about Marfan syndrome, because Marfan syndromes can also cause subarachnoid hemorrhage or CCD. So first line investigation, we said CT, non-contrast brain CT. Because this non-contrast CT, generally what they say is within the first 5 to 6 hours, the CT is highly sensitive. But this patient, what they're giving in the scenario, 3 hours, but still it's negative. So after 6 hours, the sensitivity of doing a CT goes very low. And then in that kind of scenario, if the CT is low and you are still thinking normal, you are still thinking, you have to go with a lumbar puncture. Now, problem in doing with a lumbar puncture is you have to always exclude that the patient is not having papilledema. If there is papilledema, you can't do a lumbar puncture because that means intracranial pressure is high and you can't do anything about it. So what you see in the lumbar puncture is classically there will be xanthochromia. And make a very interesting thing. You don't do a lumbar puncture and take CSF and put it to one tube and keep. You put it to several tubes because make a differentiate කරන්න කොහොමද? Sometimes in lumbar puncture there can be a traumatic blood coming out. So එතකොට කොහොමද අපි differentiate කරන්න? ඒක ඕන තරම් වෙලා තියෙනවා. I mean, especially I can remember my first few lumbar punches I did. Blood සෑහෙන blood එනවා. මොකද අපි පුරුදුත් නැහැ. පස්සේ යන්න CSF හරියට පුළුවන් you can make the puncture. So you have to remember there can be traumatic. So ඒක නිසා tubes ගොඩකට දානවා. When you put this into many tubes, if there is persistent red blood cells in all the tubes, then you're sure there is a subarachnoid hemorrhage. But if the red blood cells are gradually reducing, then of course it's a traumatic tap. And after you diagnose subarachnoid hemorrhage, what is the next investigation you should do? Next will be the CT angiogram. CT angiogram එක brain එකේ කරනවා. ඊට පස්සේ you see where the bleed is, where the aneurysm is, and you see the aneurysm. Sorry, ඊට කලින් in treatment there are some important things MCQ වල අහන එක. What is the treatment of choice? Treatment of choice you have to quickly reduce the blood pressure, and you have to start with nimodipine because nimodipine දෙන්නේ ඇයි? Nimodipine will stop vasoconstriction because the blood ආපු ගමන් brain එකට vasoconstrict වෙන්න ගන්නවා. Vasoconstrict වුණොත් මොකද වෙන්නේ? brain damage එක වැඩි වෙනවා. So nimodipine එක very important. nimodipine දීලා brain absorption brain එකේ vessels ටික constrict කරන්න නැතුව තියාගන්න එක. That is very important. And then you refer to the neurosurgeons. It like කියනවා ඒගොල්ලෝ සාමාන්‍යයෙන් you have to quickly reduce the blood pressure reduce කරන්න සාමාන්‍යයෙන් in labetalol තමයි දෙන්නේ. And then they will take to the theater එකේ තියෙනවා ගොඩක් වෙලාට කරන surgical clipping කරනවා. එතන හොයාගෙන CT angiogram එකේ they can clip it. So ඔය ටික තමයි important දේවල්. මෙහෙම patient කෙනෙක් ආවම generally you have to monitor for vasospasms. මම already told hydrocephalus වෙන්න පුළුවන්, increase intracranial pressure වෙන්න පුළුවන්, and they can have ECG changes based on the ECG changes you can get because when there is blood in the heart, in the brain, there can be ECG changes as well. So it is very important to identify it. And other thing is hyponatremia. Because hyponatremia මොකද වෙන්නේ? sodium අඩු වුණාම මේ අපේ blood වල brain cells kind of swell up and there will be brain edema. So this will further increase the brain damage. So therefore you tend to keep the sodium in a bit of a higher state in subarachnoid hemorrhage. So you have to always maintain the sodium above normal. I think I told everything about SH. Question, there is a question here. Give me a second. Yes, I think අහලා තියෙනවා about the exam. I think I will cover that part at the end of the SB. It's a very good question. Yeah, good, very good. Excellent question. I mean, I'll answer that. I have answered it before. Yeah, I'll talk about it. So I think the type 1 diabetic question was done. DK එකක් නේ. I think ඒක මම අහන් හිටියා කරනවා. Right. So next question, 42-year-old farmer, dry zone, presents with progressive fatigue and nocturia. BP 150/95 චුට්ටක් high පැත්තට. Urine sediment is bland with proteinuria. Ultrasound shows small echogenic kidneys. He does not have any diabetic. So what is the management අහනවා? What is the diagnosis? So what is the diagnosis? සිංහලෙන් තමයි ලස්සන නම තියෙන්නේ මේක actually. So we are getting an answer. DK කියලා? I think DK question was done, right? So we are doing question 4. And very good. So correct answer. This is, you all are thinking this is a chronic kidney disease. And so chronic kidney disease is common in Sri Lanka. And what is the commonest cause for chronic kidney disease? Is diabetic. Now, this case, what are the things pointing out? That's what you need to know. What are the things pointing out towards CKD? One thing. කෙලිම කියනවනේ presenting with fatigue and nocturia. Nocturia, fatigue, well-known causes of CKD. CKD were symptoms, in other words. And they will generally have high blood pressure. They will have mild proteinuria and bland sediments. Ultrasound කරාම ඒකත් වෙලාවට AKIද CKDද කියලා වෙන් කරගන්න බැරි නම් ultrasound කරනවා. Their kidneys will be constricted. And if you do a full blood count, hemoglobin will be low. And if you do electrolytes, their potassium will be high, calcium will be low, blood urea will be high. So these things, based on all these things only, you can make the diagnosis of CKD. And CKD, there can be multiple causes. Causes ගත්තම CKD kidney එකේ ඉන්න හැම structure එකක් නිසාම එන්න පුළුවන්. So CKD එන්න පුළුවන් first ගත්තම glomerulus එක. Sorry. Kidney එකේ first thing, start with the glomerulus. Glomerulonephri. Sorry. Sorry about it. So if you take the glomerulus, there are glomerulonephritis, nephrotic syndrome. And then if you take the interstitium, there is chronic interstitial nephritis. And then if you take the collecting ducts and if you take the rest of the system, they can have obstructive uropathies, and obstructive uropathy stones and all that can cause. And ඊට පස්සේ bladder එකේ ගත්තා, bladder එකේ generally it doesn't cause CKD per se unless both entry points are involved. So there can be multiple causes for CKD. It's a very, very complex disorder. And here they clearly point out the diagnosis. ෆාම කෙනෙක් ලංකාවේ ෆාම කෙනෙක්ට එනකොට dry zone එක කියලාම තියෙනවා. So there is a chronic kidney disease of unknown origin. රජරට වකුගඩු ප්‍රදාහය කියලා කියනවා සිංහලෙන්. So this they on and off they ask questions. Diabetic ketoacidosis question was done, right?
Yes, I thought it was question number 3, but we're on 4, no?
Oh, okay, it's 4. Yeah, cool. Okay, thank you. So this is a CKDU. So how you diagnose CKDU is they don't have diabetes, they don't have long-standing hypertension, there is no glomerulonephritis, kidney, there's no structural disease. Generally, in the dry zone, in the agriculture areas, generally these farmers are involved, and they have several, and rarely they can ask questions, because I can remember when I was a medical student, for final exam they asked CKDU as well, because why I remember is because nobody even like bothered reading anything about CKDU. So that's why. So you don't have to read further on this and waste time, right? So basically the high prevalence district you can see is Anuradhapura, Polonnaruwa, and North Central province is common. So farmers, especially males, and they are generally affected. And So cause එකක් නෑ. ඒකට they have postulated multiple etiologies. Nobody knows why it's happening. They think that they are being dehydrated all the time. They are exposed to pesticides, herbicides, fertilizers, and especially this arsenic. And so we don't know what it is, and something that this is due to water වල මං කිව්වා arsenic and fluoride content and can also change. So nobody knows, but it is there. What you need to know in the MCQ, commonest city. Second thing is, what is the histology? So they have chronic tubular interstitial nephritis actually. So there is tubular atrophy and all that. So that is all you should remember, because chronic tubular interstitial nephritis is very common in Sri Lanka again. Problem is you have to exclude other causes, infections, especially tuberculosis can cause tin. So all these things should be excluded. And මුකුත්ම reason එකක් නැත්නම් you label, if it's a farmer, young male, you label as this. So that is all you should remember. And their treatment doesn't change because there is no specific treatment for this. You will just have to manage the patient symptomatically, correct the hemoglobin, give iron therapy, and make sure the potassium is low, and try to keep the potassium in normal level. If the patient goes into CKD stage 4, you start talking about dialysis and renal replacement therapy, or even kidney transplant. And once the patient goes into end-stage kidney disease, you have to talk with the patient, decide going for dialysis or not. So those are the things you have to manage in these patients. I think that is enough for the exam. Then question 5. 32-year-old man is brought after pesticide injection. So, question 10. Sorry. So, brought with pesticide injection. He is sweating, salivating, and bronchoria, meiosis, fasciculation, bradycardia. Oxygen saturation is falling despite oxygen. So what is the diagnosis here? And it's very clear cut. Anybody?
Organophosphate poisoning.
Excellent. Excellent. OP poisoning. So it's a classical scenario of OP poisoning. And I think there's a mnemonic cause of, I mean, you remember the features, dumbbells කියලා මට මතක විදියට ඒක mnemonic එක ඒ කාලේ පාඩම් කරේ අපි. So what happens in OP poisoning, it is very common again. ඔය මේ කොහෙද අනුරාධපුර පැත්ත පොළොන්නරුව පැත්ත internship කරොත්, it is crazy. People, they come and they come. It's very common in those areas. කොළඹ පැත්තට වෙන්න නම් ටිකක් අඩුයි, but කොළඹත් you get these patients. So when you get a lot of patients, they ask a lot of questions. Simple as that. So OP poisoning වල මොකද වෙන්නේ? OP poisoning in ඔය agriculture pesticide එකක්. ඒකේ තියෙන්නේ මොනවාද? acetyl cholinesterase. And because the acetyl cholinesterase මොකද කරන්නේ? accumulate වෙනවා. එතකොට I mean there will be lot of acetylcholine in the මොකද්ද in the neuromuscular junction. So what happens when there's a lot of acetylcholine? It goes and stimulate basically the muscarinic receptors, and even the nicotinic receptors it can stimulate. So ඔය ටික තමයි OP poisoning වල mechanism එක. Just remember it, that it is acetylcholinesterase inhibitor. As a result, acetylcholine increases. So acetylcholine වැඩි වෙනවා කියන්නේ අපි පොඩි කාලේ neurology අනම්මනම් වල physiology වල එකේ ඔක්කොම parasympathetic nervous system එක activate වෙන්නේ. So what happens is basically feature is parasympathetic වුණාම they have ඔය මතක තියාගන්න dumbbells එකෙන් හරියට ගත්තා නම් features ටික ඔක්කොම cover වෙනවා. dumbbells එකේ D is diarrhea, U is urination, M is meiosis. B for bradycardia, bronchoria and bronchospasms. මොකද ඔක්කොම දැන් මේ වෙනවා spasms උත් යනවා. ඊට පස්සේ E කියන්නේ vomit වෙනවා, emesis. L means lacrimation, කඳුළු වෙනවා. S is salivation and sweating. Not sweating, no, it's salivation basically. You can't get a lot of sweating in this thing. So these are the features. Yes.
It's lacrimation. The other one is
Salivation.
Is there one? Salivation. Okay.
Yeah, because their parasympathetics are activated. මේ patients එනකොට ඒ කියන්නේ වෙලාවකට you can see from the I mean ඔය HO කාලේ මේසේ ඉඳන් ඉන්නකොට පේනවා මොකද one thing is the smell. You will never forget that smell. මුළු ward එකම ඒ කියන්නේ මේගොල්ලෝ එන්නේ වමනේ පෙරාගෙන ඊට පස්සේ නහෙන් පොටු වෙනවා කඳුළු වෙනවා කටෙන් මේ කෙලවැක් කරනවා. So it's like, I mean, it's a classical scenario. You can easily identify with the smell and all these features. You will never miss it. So diagnosis is simple, but thing is you have to worry about here is they have a lot of bronchospasms. They can go into respiratory failure. They can have bradycardia and their heart can stop. So just remember that these things can happen. And of course, there can be respiratory paralysis. So what we try to avoid is basically that. When a patient like this comes, first thing you have to do is you have to examine the pupils. Pupils will be pinpoint pupils. And then chest there will be wheezing, secretions, and the cardiovascular there will be bradycardia. So test කරන්න නම් එහෙම ලංකාවේ නම් ඔය දේවල් යවන්නේ නැහැ, but I mean other countries of course they can check this acetylcholinesterase level in the red blood cells and all that, but in Sri Lanka they don't check. We generally manage it clinically. So obviously when a patient comes ABCD unknown because airway is obstructed, secretions you have to suck out the secretions, give oxygen, you might need intubation and urgent ventilation. And so basically කොහොමද මේක ඇඟට එන්නේ, some guys they drink මැරෙන්න ඕනේ කියලා බොනවා, and some occasions from the skin also this can be absorbed. It's easily they can be absorbed from the skin as well. And also inhalation can also cause toxicity, but it is bit less. Injection වල තමයි toxicity එක ගොඩක් වෙන්නේ. And so ආපු ගමන් ඔය ABCD බලනවත් එක you have to take off the clothes and all that, and then commonly they ask in the exam is what is the medication you can give, which is atropine. So atropine is a muscarinic antagonist. It completely blocks the muscarinic effects of acetylcholine. And how you give is you have to increase the dose. It can dose එක double කර කර දෙන්නේ. So ඔය අපි බ්‍රැඩිකාඩි එකක් ආවම හાર્ට් බ්ලොක් එකක් 6 මිලිග්‍රෑම් එකක් දීලා ඉන්නවනේ ෂේප් එකේ. ඒ වගේ බෑ. First 6 දෙනවා 12 දෙනවා 18 දෙනවා එහෙම. You have to keep on doubling it and increase the dose. So that is very important to identify. And කොහොමද දෙන්නේ මේ atropine එක නවත්තන්නේ කොහොමද? Because there can be atrophinization endpoints තියෙනවා. ඒ කියන්නේ when should you stop giving atropine? නැත්තම් දිගටම දිදී යනවා. The one thing is you have to auscultate and see whether the chest is dry, and secondly whether the axillars are dry, and then secretions are reduced. Then you know that you can stop atrophinization. And you have to remember another thing, MCQs they ask whether atrophinization reverses the muscle paralysis. It does not reverse the muscle paralysis because it takes some time to reverse the muscle paralysis. It doesn't, I mean, atropine, it's not a magical drug which will rapidly improve it. And then with atropine, there's another drug called pralidoxim. Just remember it, just only the name is enough. Pralidoxim also can be given. And it's especially important intermediate syndrome කියලා එකක් තියෙනවා. ඒ intermediate syndrome එක එන්නේ after 1 to 2 days එන්නේ. They will have paralysis. Just remember intermediate syndrome paralysis. And then there's another entity called organophosphate induced OP induce neuropathies enna puluwan. Just I think you all only need the name only. So I think we talked a lot about OP poisoning. Any questions? Okay. So next one, 55-year-old cirrhotic patient with fever, abdominal discomfort, mild confusion, tense ascites. Acidic fluid analysis is neutrophil එක 420යි. So it's a crystal clear diagnosis. What is the answer? What is the diagnosis and what is the answer?
Is it spontaneous bacterial peritonitis?
Excellent. Why are you saying it's spontaneous bacterial peritonitis here?
Because there is fever, abdominal discomfort, and the ascitic fluid. The neutrophil count is very. And it's a cirrhosis patient all.
Exactly. Cirrhosis patient. So as you said, the neutrophil is it's a diagnostic because it has a figure as well. More than 250 neutrophils is there. It is diagnostic of SBP, nothing else. It's a confirmatory one. So SBP is a very tricky thing. Why? SBP අපි නිකන් simple ගත්තට it's SBP in the cirrhotic patients, if they develop a single episode of SBP, their mortality increases rapidly and they go into decompensation rapidly. So it is quite devastating SBP. What happens is cirrhosis patients obviously there is low albumin levels, renin-angiotensin system is also messed up, is activated as well. ඒක activate වුණාට පස්සේ මොකද වෙන්නේ? Fluid retention වැඩි වෙනවා, albumin අඩු වෙන නිසා තවත් මේ fluid වැඩි වෙනවා, edema වැඩි, peritoneum එකේ fluid වැඩි. So that is how you get ascites, and top of that you get portal hypertension because of the liver. So portal hypertension එක නිසා fluid වැඩි වෙනවා. So as a result fluid gets accumulated, and so මේ fluid එකට easily මේක නිකන් culture medium එකක් වගේ organisms එනවා. කොහෙන්ද organisms එන්නේ? ඔය gut එකේ translocation එන්න පුළුවන්. ඔය UTI එකක් තිබ්බ මේකෙන් එන්න පුළුවන්. So and all these things can cause an infection. So this, as you said, the clinical features classical. They can have abdominal pain, fever, tenderness, and they can have confusion because they can easily go. My question confusion so it can patient mild confusion, so they can go into a mild hepatic encephalopathy as well. And always remember they can go into hypotension. I mean, I still can remember during my final year it was told hypotension is a very important cause for SBP කියලා. And I can remember HO කාලේ patient CLCD patient කෙනෙක් ආවා with very low blood pressure. There was no cause, no fever, no this thing. අපි මේක aspirate කරලා බැලුවම it was a SBP. So it is important knowing the clinical features. And එහෙම නැත්නම් any cirrhotic patient with ascites who deteriorates, you have to think that this is SBP. And so typical ascites, I mean, in cirrhosis, what happens is in especially SBP, so PMN count will be increased, protein will be very low, culture can be positive. So culture, there can be multiple organisms එන්න පුළුවන්, but staph ඒවා තමයි ගොඩක් E. coli and staph තමයි you have to think about it in SBP. අර ගොඩක් organisms කියන්නේ the classical thing in SBP is there will be only one organism. If there are multiple organisms, you have to think about a secondary bacterial peritonitis. It's not a spontaneous bacterial peritonitis. And treatment is generally it's a third gen cephalosporin තමයි treat කරන්නේ. So that is important. And some of these trials, they show that giving albumin is also important in preventing in the treatment of SBP. ඒකත් question සොලා අහන්න පුළුවන්. And the next common important thing is the prevention. So when they have one episode of SBP, you have to prevent the next episode. Generally, norfloxacin is the drug of choice to long-term prophylaxis. Then daily dose එකක් දෙනවා norfloxacin to prevent it. I think SBP that's all they can ask probably. Yeah.
So,
Next is
what was the
yes.
given? Albumin. I didn't hear that properly. In
Sorry.
SBP. Is albumin given in SBP?
Yes, you can give albumin because giving albumin has shown to have a mortality benefit in SBP, especially when the albumin levels are very low. So it can be beneficial in giving. Yeah.
Okay, thank you.
Next question. Anybody? Answer it. So 68-year-old, bilateral shoulder pain, hip girdle pain, morning stiffness, ESR elevated, classical. මොකක්ද මේක diagnosis එක? Pain එකක් තියනවලු scalp tenderness and jaw pain. So what is the diagnosis and what is the answer?
Temporal arteritis and polymyalgia rheumatica.
Excellent. I mean, that's very good. So it is and
the treatment.
yes, treatment will be high dose steroid. That is classical. So polymyalgia rheumatica, again, a very easy disease to diagnose. It's an inflammatory condition because now what you need to remember is that this can be confusing with the giant cell arteritis because these are all large vessel arteritis, and they kind of coexist. Like not all polymyalgia patients have giant cell arteritis, but some of them can. It's just associated. That's all. Sorry. So what they have is the characteristic you have to remember is always the age will be more than 50. Generally more common in ladies who are 70 to 80 years of age. And it's an immune mediated thing. You have to remember the classical features are they have bilateral shoulder pain. What they classically tell is උදේ පාන්දර ඇහැරිච්ච ගමන් shoulders රිදෙනවා and ටිකක් වෙලා ගියාට පස්සේ ඒක නැති වෙලා යනවා. Because of the pain, they can't get out of the bed, they can't dress in the morning, they can't lift arms, they can't stretch, and that is the classical symptom. But sometimes they have these hip pains and back pains and all that, but අරක තමයි classical. Low grade fever එකක් කියන්න පුළුවන්, weight loss එකක් කියන්න පුළුවන්, and some when the features coexist, they have giant cell arteritis. Now, giant cell arteritis is what? They have scalp tenderness, any headache. In other words, any headache in an elderly person who's more than 50 years old with a high ESR, until proven otherwise, should be giant cell arteritis. Why you cannot miss giant cell arteritis is giant cell arteritis, if you don't treat with steroid, it can go into blindness. And කොච්චර එතන inflammation එකක් තියෙනවද කියන්නේ, they have jaw claudication, which means when you open the mouth, when you chew, when you talk, there will be pain. So and how you diagnose it is like එතන cell එකක් කරන් ඒකේ you can do a biopsy, temporal biopsy you call the temporal artery biopsy. So you can cut the temporal artery, which is superficial one, so you can take a piece and send it for biopsy. But now a lot of people, they do the ultrasound scan of the temporal artery, so you can see the inflammation. And investigation wise, their ESR, CRPs will be extremely high, and they will have a very dramatic response for steroids. කොච්චර dramatic ද කියන්නේ, within about 48 hours their pain will improve. Some of them, they will tell නිකන් අර දෙයයන් වහන්සේ දැක්ක වගේ ඇවිල්ලා කියනකො they suffer so much with this, and steroid එක දීපු ගමන් it's like a miracle, and the pain completely vanishes after about 48, 72 hours. Like, So treatment will be very high dose of steroid. It will be given for some time, and then it will you have to give it for years, actually 1 year, 2 years, with a long time, and you have to gradually reduce it. Why you give it for long time is because they can have relapses, so you have to stop it. And if there's giant cell arteritis, they can go into blindness, so all those things should be stopped. Yeah, I think that is about that as well. So I'll just talk about there was a request about the exam thing. I'll talk about it, but any questions regarding the anything you want to discuss more about what we already discussed?
Sir, how do we differentiate polymyalgia rheumatica and giant cell arthritis?
Yes, polymyalgia rheumatica, it's like, we'll think it like a spectrum. Sometimes some patients have both. But if you take giant cell arteritis, same age group, same ESR high, but what they will have is classical headache, jaw claudication, visual disturbances. Polymyalgia rheumatica, classically they have girdle pain, shoulder or hip girdle pain with early morning stiffness. But sometimes these two can overlap.
So in this question, are they overlapping here, or is it just?
Yes, this question it's overlapping.
No?
Yeah. Good. So, yeah. So, someone has asked, can you give an idea how to understand or how to study based on the questions and answers? Yeah. So, I'll tell you the trick. This is a golden trick, and not only me, all most of my colleagues who have done postgraduate, who have passed all the exams, they use this method as well. There are two methods to study. It's simple as that. One thing is question to answer technique, question to book technique. Other thing is book to question technique. So what people think is we think we want to study everything. So අපි පොත ගන්නවා, cover to cover පාඩම් කරන්න හදනවා. Then we think we can do questions. That is a very poor strategy to do for an exam, especially a competitive exam like ERPM. Because why? These are MCQs. They have an MCQ bank. ප්‍රශ්න හදන්නේ එහෙමයි. They have a bank. ඒ bank එකේ තියෙන questions ඒකට දානවා. ඒ bank එකට questions දාන්නේ කවුද? Mainly senior consultants, right? ඔය professorial units වල ඉන්න මේ lecturers ටික. So they make questions and they put and ඒකෙන් bank එකෙන් ගන්නවා questions. So what happens is, the best way is, first thing is do the model questions. Where classes වල දෙනවා, කාගේ class වුණත් කමන්නේ නැහැ. ඒ කියන්නේ now this method මොන class එකට ගියත් කවුරු teach කරත් this is the way to do it. So do the questions, model questions ටික ඉස්සලා කරන්න, ඊට පස්සේ do the past papers. Past papers is the utmost important thing. Why? Past papers මං කියවර bank එකකින් තමයි questions they will be taking. So you will be getting similar questions for the exam like the past papers. So, and now you saw how we did the questions today. Now from one part we went around one subarachnoid hemorrhage question again. Mulu subarachnoid hemorrhage I discussed. So this is how you should study as well. Again, MCQ එකට උත්තර හොයන එක නෙවෙයි කරන්න ඕනේ. MCQ answer is it's pointless. We don't care whether the answer is there or not. Just try to read around. Now you read the question and think the answer. So if you can't get the answer, you read around that area. Answer එක හම්බෙනකම්ම read. හම්බුනට පස්සේ still go and read, because the question they will ask for the exam might be a different one than the answer. So you have to read around. එහෙම කරොත් it's a psychological thing as well. මොකද when you read, now අපි එකනේ කියන, for an example, අපි patient කෙනෙක් බැලුවොත් hospital එකේ patient කෙනෙක් බලලා ගෙදර ඇවිල්ලා කියවුවොත් it's there in the brain for a long time. Sometimes lifelong it will be there. Same as that. patience බලන්න බෑනේ හැම එකටම. So at least MCQ එකක් බලලා questions බලනකොට මේ theory බලනකොට it it like it retain the the knowledge retention becomes more than because majority of the things කියවට පස්සේ ඒක අමතක වෙනවා. පොතෙන් cover to cover පාඩම් කරොත් ඒක අමතක වෙනවා. So this is the most successful method to study for any exam, especially ERPM. And this is what I have been always telling අපේ මේක කරලා මම දැන් ගිය පාර first වුණා, third වුණා, 11 වුණා, 20 I can't remember 23 or something. So me ඔක්කොමලා they studied like this. That is how they like got through the exam as well. I'm not telling මම නිසා වුණේ කියලා කවුරු නිසාවත් exam එකක් pass වෙන්නේ නැහැ කවුරුත්. Only because of yourselves. But this is the way to do it. Yeah, I hope I answered your question. Yes. So it's question to answer, but Hasim, it's not only the question. So your goal should be then MCQ එකේ වාගේ තියෙන්නේ හිතන්න මේ rheumatoid arthritis එකකින් you at least try to cover majority of the things in rheumatoid arthritis. So then your knowledge becomes more අර ප්‍රශ්න scenario එක හිතන නිසා ඔයාගේ brain එක retention එක වැඩි වෙනවා. And you might even read the question which is going to be asked in the exam. So you can do it. If you're not motivated, අර බෑ negative thoughts දදා ඉන්නවනම් මේක කරන්න බෑ මොන කාර්යයකටද medicine කරේ ඕම දේවල් හිතනවනම් it's not going to be easy. But if you be very positive and if you think that you're going to do it, and if you do with the correct system, you can do it. There's no reason you can't. Just පොඩි කට්ටක් කන්න තියෙන ඕක කන්න. It's worth it, trust me. Anything else?
So what courses of yours do you recommend joining? Because we just have like about 3 weeks or so for the exam in June.
Yes. Yep. I can hear it. My AirPods was messing up.
So I asked, what courses do you recommend joining? Because we just have about 3 to 4 weeks for the exam, no?
Yes. So this few weeks, don't try to do a lot because you can't obviously read everything, no. So
Yeah.
best thing is to go with the past papers. What I would do is, I would do the past papers now, because past papers. Have you all done the past papers? Finished? If the past papers are not done, you do it, because past papers sometimes some exams I did the important papers couple of times as well, because it is that important to answer these questions. So don't go through everything, just from the question to answer, go with this strategy. So 3 weeks is enough to utilize it. You can do it, because this is not only medicine, no, there's other things going on as well. So yeah.
Okay.
So I think, if there's any question, you can put in the, I think there's a group, right? So there a group group then I generally answer, or you can message me. I would generally answer if I have time. So good luck, study well, you can do it. Yeah, we'll conclude from now here. Okay, see you.
Thank you, sir.
Okay, see you.